Hello everyone, my name is Logan Foreman and this is my evidence-based practice presentation for Nursing 830. In this presentation, I'm going to go over my PICO question assessment, my literature search techniques, a discussion of available knowledge, an overview of current recommendations, the application into nursing practice and future initiatives, and a conclusion of my topic. So my topic is going to be on heart failure. So what is heart failure? Heart failure is simply a reduction in the pumping action of the heart. It has many forms and causes. How does it impact our patients in nursing? Heart failure impacts nursing by what our patients require in order to maintain and thrive. So what can we as nurses do about this? We can educate and motivate our patients so that they can be the best that they can be with this diagnosis. So my PICO question is, in adults with congestive heart failure and acute decompensation, does the initiation of early mobility therapy compared to bed rest precautions reduce 30-day hospital readmission rates? My population is adults with congestive heart failure. My intervention is exercise, ambulation, mobility, or early mobility. Of note, they can be patients in bed but still exercising in bed. They don't necessarily have to be ambulating in their room or in the hall. My comparison is going to be ambulatory or exercise versus those on bed rest. And my outcomes is going to be an increased risk for 30-day readmissions and poorer outcomes. So to help put this into perspective, I wanted to make sure everyone saw the need for improvement in this area and kind of show heart failure by the numbers perspective. Heart failure is the leading cause of death for both men and women in the United States. Every 33 seconds, an American dies from a heart failure related diagnosis. Heart failure costs the American taxpayers $250 billion a year for related care. And in addition to that, 30-day readmission rates from heart failure is estimated to cost an additional $70 billion by 2030. So this is equating to nearly 1 in 4 people are readmitted to the hospital for an acute CHF exacerbation. So simply put, what can we as nurses do about this? So a literature review of the literature I use for my PICO question is I use PubMed mostly for a lot of my research. PubMed just because of the extensive access to results and the integrity of the medical science field that a lot of their research has. And I use CINAHL because a lot of the studies are nursing based that were applicable to my topic. So researching current literature, a lot of the literature is current and there's a lot of extensive data and research into it, but I found some limitations that a lot of the studies all used the backbone or almost kind of landmark studies that were initially used, and not a lot has deviated from that. So I thought this is definitely a lot of opportunity for me to contribute to the field and provide a new innovation solution to the problem. So next, challenges of the search process. Some of the challenges I found are limitations that a lot of the studies were related to that are current are related to LVAD or left ventricular assist device patients. So it doesn't necessarily look at all different types of populations. It kind of seems to be all focused on LVAD in current literature. So concluding on my literature search, I used key terms, mesh terms to put simply, they're called medical subject headings from PubMed. I used, here you can see on the left, 30-day readmission rates, ventricular function, heart failure, CHF, congestive heart failure, ambulation, and exercise, and heart failure rehabilitation, to name a few. For my research limiters, I kept most of my studies that were done in America, Europe, Japan, or Canada, just because I wanted to make sure I used areas where integrity was of utmost focus. I also included studies that were 5 years or less, although some outliers, such as groundbreaking studies, I did include. All of my studies were systematic reviews or randomized controlled trials. I excluded pediatric-related studies, and the researchers also had to detail the patient was diagnosed with CHF. And I also excluded studies that had CHF patients that also had pulmonary-related issues noted, just because I found this made things a little more difficult to isolate, and it kind of made issues on ambulatory function that was superimposed from a pulmonary function. So I wanted to make sure it was very specific. An overview of findings. The literature, like I said earlier, was expansive, and it did require a significant amount of applications to find specific research that I could utilize. So by that I mean I had to find certain techniques or Boolean applicators of and or functions to make sure I found exactly what I needed, because the field was very saturated with different types of CHF, not specific to just ambulatory function, which I found was also an opportunity for me to contribute to. So a review of my articles. For the 5 articles, the first one was done by Marone and colleagues. In this patient population of the study, they used post-operative LVAD patients in the hospital, and they utilized an ambulatory progressive mobilization protocol that was started in 7 to 10 days post-operative. So the patients progressed through this program, and they wanted to track overall their improvement. They did find an overall improvement in activity tolerance. And how this applies is that improving outcomes and decreasing risk factors so that patients can have better outcomes outside of the hospital and improve in their lives with this diagnosis. Another study I found that was very interesting was done by Penn and colleagues. It assessed a single preoperative intubated patient. The patient was intubated and going through a progressive ambulatory protocol to see if he could get to a status point where he could survive an LVAD procedure. He needed to have the LVAD procedure done in order to survive. And the outcome of that is he was able to go through this 5-week intense PT therapy program while intubated, like I said, and able to receive the surgery and survive the surgery. So the application to this is simply put is that even an intubated patient can participate in an ambulatory therapy program. The next study I wanted to utilize, done by Sevelian, Kazas, and colleagues. So they looked at recently admitted CHF patients that were discharged home, and they utilized semi-structured interviews for these patients to determine their point of view on improvements or areas of clarification patients needed. So what they were able to find is that by increasing understanding of the educational needs for patients and resources these patients needed when going home, so these patients could focus on time outside of the hospital and stay out of the hospital and reduce those 30-day readmission rates. So the application of this is patients need to understand what is available to them, and nurses need to do a better job, and nursing overall, of what patients need to manage CHF at home. Another study I wanted to include was considered one of those older landmark studies done by Sullivan and colleagues at Duke University. CHF patients underwent a progressive ambulatory exercise bike program. And for this, they had an intravenous Swan-Ganz catheter administered for cardiac monitoring so that they could understand the physiological adaptations in live time throughout this protocol. So an outcome of this, simply put, is they were able to determine that there wasn't necessarily an increase in cardiac function, but there was a circulatory adaptation and improvement in managing symptoms. So these patients were able to not necessarily have an improvement in their cardiac function that were diagnosed with CHF, but these patients were able to have a circulatory adaptation so that symptoms were better managed through the increased exercise tolerance. So their symptoms were much more subtle to them or not even noticed to them. So this was a very landmark study because it was able to show that a progressive mobilization can increase tolerance in managing symptoms outside of the hospital. And the final study for this PowerPoint presentation was done by Kakutani and Associates. It was done in a Japanese hospital where they actively were doing an experimental mobility program in inpatient CHF patients. And so this was a nursing-driven protocol that was aimed to increase activities of daily living compliance. So this nursing-driven protocol was done to see if they could use ambulation or other exercises to increase a patient's ADL so that they could be more successful outside of the hospital and at home, ultimately reducing 30-day readmission rates and other CHF-related exacerbations. So the outcome was patients were able to progressively increase physical tolerance. They were able to show a 30-day readmission rate was decreased. And they were also able to show some other sorts of data that showed that patients were doing better outside of the hospital and were able to show and able to detail their activities of daily living. So the application of this, that a direct nursing-driven protocol to ambulate patients is successful and can be utilized in the hospital for patients to do better outside of the hospital. So the recommendations from all of this I wanted to go over was I think it's very important that nurses initiate an ambulation protocol, or we have an initiation protocol within 48 hours of admission, regardless of the patient's risk factors. Because like I discussed earlier, even an intubated patient was able to go through a progressive mobility therapy. Patient education and the importance to health and overall functionality, and that the vital part education plays on patients doing better outside of the hospital and providing them with resources that they can understand so they know what's available to them when they have a question or a concern or think they're experiencing an issue. Another recommendation is decreased length of stay and 30-day readmissions. This is the ultimate goal of all of this, is to help patients do better at home and increase their tolerance in their activities of daily living outside of the hospital. Next is the physical activity is appropriate regardless of a patient's Johns Hopkins highest mobility score, or the JHHML. I think this is a great tool to use, but I do not think a score on this should necessarily exclude a patient from being able to participate in ambulatory functions with a CHF exacerbation. I think this is a tool we need to use in our assessment, but I think nurses should use this cautiously, and that if they see a score that necessarily doesn't reflect what the patient can do. The next will be the discharge planning education for at-home needs as a recommendation. I think education is optimal, like I said earlier, but I think at the discharge process, beginning to understand what this person's going to need. Because every patient has different assets or different educational needs and everything like that to understand their diagnosis. So we need to begin the process of understanding what this person's going to need. Are they going to need cardiac rehab? Is this patient going to need X or Y? I think it's just very important at the beginning to begin to assess the discharge planning needs for this patient so that they can be successful at home, and not just a blanket program that a lot of places utilize for CHF exacerbation patients. An application of findings. So next, what impact will this have on our patients? I believe it'll have an improved quality of life and living, a reduction in mortality and morbidity, an improved functionality of a patient's activities of daily living, and less time in the hospital, which is our overall goal. So next, an application of findings I found is you have to think about nursing ratios and able to maintain these recommendations. If we're ambulating these patients doing this strict exercise programs and utilizing these protocols, is it possible for a nurse to even do this? So I think nurses need to maintain these initiatives and provide optimal patient care, but executives need to also understand the cost savings and lower ratios in keeping patients with CHF out of the hospital. So I think that needs to be considered in managing these nursing ratios so that patients can do better outside of the hospital and overall reduce costs. I think next is how can we motivate our patients to participate? I think this is one of the toughest parts of nursing or anything in life, and patients need to believe in themselves. So I think we need to educate, demonstrate, and illustrate through examples so patients can see that grass is greener on the other side, and show them this is what you can do. This is what you can be. I think if we are able to illustrate that and show patients this and not just tell them this, I think they'll be able to understand what they can do and not limit themselves, such as that example I showed of ambulating a patient that was intubated in the hospital. So some final thoughts. I think it's very important that we begin to innovate some solutions to improve outcomes for those in all settings, not just those in large city medical centers. To do this, we need to start with the basics, such as simply walking and keeping active. But we also need to be listening to our CHF patients and understand their exact struggles and what they need to be the best they can be. So I wanted to make sure I brought this picture in to show an actual patient from the Perome study that he's ambulating while intubated so that he could get stronger and live through the LVAD procedure. I think it's kind of a testament to show what you can do if you put your mind to it. I want to thank everyone for listening to my PowerPoint presentation, and thank you very much and have a good day.